A very pleasant afternoon to everyone present over here. Hope you all are having a good time. Now, we present Group F and the topic of discussion is management of myocardial infarction. So we'll be discussing on the certain headlines. Firstly, we'll have introduction, case presentation, diagnostic test, management, objectives, conclusion, and a take-home message. So before entering into these topics, first let's know something about ischemic heart disease. As we have already discussed in biochem department, but also, like it's very clear by the term itself, ischemia, that means the loss of blood supply to any particular heart tissue. And as we're talking about the heart, that means it's the myocardium or endocardium or pericardium. Now, as if a person is suffering from this ischemic heart disease, he may be having a spectrum consisting of myocardial infarction, angina pectoris, chronic ischemic heart disease, or sudden cardiac death. Now by this it's clear that myocardial infarction is just a spectrum of ischemic heart disease. Now entering into the management, we'll have the definition. Firstly, by the World Health Organization definition, it says the demonstration of myocardial cell necrosis due to the significant and sustained ischemia. And this is the Levine sign. The characteristic feature of myocardial infarction is this Levine sign. Now before jumping into the typical management of myocardial infarction, let's see a case.
Ram Bahadur Basya, a 50 years old married businessman, returns home from his work. He suddenly develops central chest pain radiating from jawline to the left shoulder towards the inner arm. Suddenly he starts sweating, along with shortness of breath, dry mouth, lightheadedness, and anxiety. He rushes to drink water for immediate relief, but couldn't get any visible relief, and he suddenly falls down on the ground. Then his son, who was present there, rushes to check for his vitals, but couldn't find any evidence, so he started performing CPR. But seeing no improvement, he immediately called the ambulance, and Mr. Ram was sent to the nearest primary healthcare center for the primary treatment. Then after, he was referred for further treatment to UCMS.
Presentation. Now for the differential diagnosis, can among the audience rule out what can be the differential diagnosis? Alright. And something else? So we have this, for the differential diagnosis, it may be angina, perforated peritonitis, pulmonary lesion, myocardial infarction, or it may be a pancreatitis. Now for the provisional diagnosis, let's into the topic. So, for the history of the patient, it was clear that the site was retrosternal chest pain, that means behind the sternum, and the pain was onset in action, and his pain was also squeezing in nature. In myocardial infarction, it could be stabbing or pricking, but in this case, it was squeezing in nature, and the radiation, it radiated from the jawline towards the left shoulder, between the shoulder blades, and to the inner arm through the axilla. And the vomiting nature was non-projectile in nature. And for the associated findings, he had this shortness of breath, some GI symptoms. For the past history of the patient, he was a type 2 diabetes mellitus patient, and he used to do alcohol, smoke, and he had no surgery or no food or drug allergy. And his father died due to hypertension. For the physical examination, we found that he had rapid breathing, fine pores, crackle sound while ascending the lungs. his blood pressure increased maybe due to anxiety or maybe decreased due to heart failure, and his skin was quite moist and warm. So for the differential diagnosis, as already explained by our biochem partner, we have two specificities basically. ECG. In ECG we have ST elevated MI and non-ST elevated MI. In ST elevated MI we can see this, the segment is elevated, and in non-ST elevated MI that means the ST segment is depressed and T wave inversion is there. And for the cardiac markers we have troponin I, which is very specific, and we have CKME. Both the levels have seen that there has been increase in this case. So this was all about the introductory part from my side, and I would like to call the other member to continue further for the match.
Okay, thank you. Now let's learn about the management of the myocardial infarction. When the patient of the myocardial infarction is present at the hospital with the symptoms, at first, specific treatment is done. For the specific treatment, 300 mg of the aspirin and the 300 mg of the clopidogrel is given. They are the antiplatelet drug and they prevent the further thrombus formation. And next is the 80 gram of the atorvastatin is given. Atorvastatin is given because it prevents the atheromatous plaque formation. One. Next, due to its pleiotropic effect of the atorvastatin, it also stabilizes the plaque. And then after the specific treatment, next treatment is the symptomatic treatment. That is the ABC. Airway, breathing and circulation of the patient is managed. Oxygen therapy is also given to the patient if oxygen saturation is less than 90%. Next, 0.5 mg of the GTN, glycerol trinitrate, is given to the patient. It reduces the chest discomfort by reducing the breath load. And 10 mg of the intravenously morphine is given as it reduces the pain. And if there is the case of the arrhythmia, hypotensive crisis, or the pulmonary edema, it is also managed accordingly. At the same time, the vitals of the patient was also monitored. 12 lead ECG was also done, and card test for the cardiac marker was also sent. After analyzing the ECG and the cardiac marker, we found that if there was the elevation in the ST segment and troponin and the CKMB were found positive. From there, we conclude that it is the case of the ST elevated myocardial infarction, that is STEMI. Now let's see the management of the STEMI. STEMI, it is the medical emergency case. As soon as we manage the case of STEMI, the more cardiac muscle can be saved. So it is said that the time is muscles. And the definitive and the primary treatment for the STEMI is reperfusion therapy. If the PCI, percutaneous coronary intervention, is available within the hospital, then we go for the PCI. If PCI is not available, then we go for the thrombolytic therapy. After the thrombolytic therapy, if ischemia is still persisting, then again we repeat the thrombolytic therapy, or until that time, if PCI is available, then we go for the PCI. Okay, if the PCI is available in the hospital, then we go for the urgent angiography. And under the angiography, if we found if the coronary artery are amenable to the PCI, percutaneous coronary intervention, then urgently we go for the PCI. If the artery are not amenable to the PCI, then we go for the CABG, that is coronary artery bypass graft. Okay, let's summarize the reperfusion therapy. The first reperfusion therapy was the PCI, percutaneous coronary intervention. In the percutaneous coronary intervention, the stent is placed on the coronary artery that avoids the blockage. But the problem is that when we use the stent, our body also that stent also behave as the antigen. So again, there may be the possibility of the platelet aggregation. To avoid that platelet aggregation and the prevention of the future thrombus formation, we use the antiplatelet drug like the aspirin. Next is the thrombolytic therapy. Okay, for the thrombolytic therapy, we use the tissue plasminogen activator. Majorly, we use the streptokinase, and the other like the antiplase or the reticulases. The major problem that we face while using the thrombolytic are, if we use the streptokinase, there may be the resistance to the streptokinase. First problem. Next problem, the patient may develop the allergic history. Okay. Other are the problem that these streptokinase are highly restricted in the patient having the internal hemorrhage or the internal bleeding. But by considering the risk is to benefit ratio, we use the streptokinase. And next is the CABG, coronary artery bypass graft. When the coronary artery are not amenable to the PCI for cutaneous coronary intervention, then we go for the CABG. When there is the triple vessel disease or left coronary artery disease or cardiogenic shock, we go for the CABG. As we said that the STMI, it is the medical emergency case, so the time frames will be maintained well. That is, fibrillatics will be done within the 30 minutes and PCI will be done within the 90 minutes. Next, you can see this is the figure of the coronary intervention where stent is placed to avoid the clotting. Next, this is the CABG. In the CABG, here we can see the great saphenous vein. We can also use the internal thoracic artery also to avoid the bypass. Okay, this was about the how we manage the symptomatic management, specific management, and the definitive management. Now, to avoid the future attack and the complication, the pharmacological management that we adopt are the 300 mg of the aspirin is prescribed, 12.5 mg of the carbidopa, that is the beta blocker, and the 40 mg of the atorvastatin is prescribed to the patient. From the non-pharmacological management point of view, the patient is suggested to maintain his or her diet, avoid the cigarette smoking mainly, reduce the alcohol intake, and the blood pressure of the patient should be maintained. Okay, this was all about the management of the myocardial infarction. Now my friend is going to summarize what was the objective of those management. Okay, thank you.
Good afternoon, everyone. So let's summarize the management of EMI. So we have general management and the specific management. Under the general management, we have first number one, maintain the oxygen therapy. Number two, maintain the blood volume by IV infusion of saline. Number three, correction of the acidosis by sodium bicarbonate. In specific management, we have 6 points here. In number one, avoidance of the pain and anxiety. For that, we give 0.5 mg of GTN, and if there is no progression in the patient, then we give 10 mg of morphine through IV route. In number two, we have prevention of the thrombosis and embolism. For that, we give 300 mg of aspirin and 300 mg of copridone. In number three, we have control of the complication. Like normally we see arrhythmia and the heart failure in the MI patient. If the patient is developing the sign of bradycardia, then we give 1 mg of the atropine through IV route. And if the patient is developing the atrial fibrillation, then we give 12.5 mg of metoprolol. In number four, we have reperfusion therapy. After doing all the primary treatment, now we go for reperfusion therapy. For that, we have 2 ways. That is PCI and the CABG. In number 5, we have prevention of the ventricular remodeling. For that, we give ACE inhibitor and alaprine and ARB losartan. In number 6, we have prevention of the future attacks. Now let's go to take-home message. Yeah, as we know, not only the older people, but nowadays every age group people are at high risk of EMI because of their lifestyle. For that, we know prevention is better than cure. So we have to maintain our diet by avoiding the fatty food. We have to by avoiding the cigarette smoking and alcohol, and we have to maintain our the blood. We have to maintain our the BP time to time, and within 6 months of time we have to check our lipid profile. I would like to thanks to Department of the Cardiology UCMS, Department of the Cardiology UCMS, Department of Pharmacology, textbook of the Pharmacology KDC Party, and special thanks to Dr. Anand Palke sir. This presentation was informative and will be helpful in the future, coming future. Thank you. inform the class to get ready for question and answer round.
A question now, only two.
What is the causes of acidosis in MI?
Okay. As we are reading under the ischemic heart disease, ischemia, there is a decrease in the blood supply. If there is a decrease in the blood supply, our cardiac muscle tries to compensate through the anaerobic respiration. One thing is that due to the anaerobic respiration, there is accumulation of the lactic acid. Due to the lactic acid, there may be the possibility of the metabolic acidosis. And next thing is that we already have discussed, there is the respiratory depression too. Due to the respiratory depression, there may be the increase in the carbon dioxide concentration inside the body. Due to the increase in the carbon dioxide, there may be the respiratory acidosis. So we can conclude there may be both respiratory acidosis, metabolic acidosis, but majorly the metabolic acidosis is seen.
As you have mentioned, clopidogrel in your slide for MI. So if the same person is suffering from gastritis, so can you give omeprazole or any PPI? And if yes, why?
So, nice question. Clopidogrel is a antiplatelet drug, so it cannot be given with the omeprazole. For the activation of the clopidogrel, there is an enzyme present in the liver, that is CYP2C19. So clopidogrel is activated in the presence of that enzyme. So our what? Omeprazole. Omeprazole is a protein pump inhibitor. It inhibits the CYP2C19 enzyme and hence there is an antiplatelet action. And there is a therapeutic failure.
Thank you.
So you can use 5 reps.
Thank you so much. Thank you very much. What are the most common arrhythmic disorders associated with MI? I think you didn't mention the treatment of ventricular fibrillation associated with MI. What is the treatment for the ventricular fibrillation associated with MI?
Can you repeat our problem?
What is the treatment for ventricular fibrillation associated with MI? You mentioned the sinus bradycardia, just give atropic. In atrial fibrillation, you give metoprolol. But for ventricular fibrillation, what is the drug of choice?
Digoxin भन्दैछ congestive heart failure.
The patient is taking ecosprin and it is within 1 year of myocardial infarction. Post is taking ecosprin clopidogrel. Now, some of your colleagues are concerned about dental extraction of almost 9-10 teeth of that patient. Now, what you will advise? Within 1 year of post-MI, patient is on ecosprin and they want to do a dental extraction. They are asking for what to do with that ecosprin. What is it? First year you can't stop. As you told, it's risk and benefit ratio. If it has to be stopped, then minimum of 5 days. You can't stop more than that. Better in first year, avoid stopping either of the antiplatelets. If you have to stop after 6 months or minimum of 5 days only.
Thank you.
myocardial infarction is a great medical emergency. Okay. So this is a top priority to manage MI case. Which is the top priority to manage a MI case? I think I could not convey myself. Look here. Management of the time is the most important in management of the myocardial infarction. Because 50% death occur between half to 1.5 hours only. If they survive 1.5 hours, 50% life will be saved. But 50% death, they occur within half to 1.5 hours. That is why chapel services are provided by the cardiac center. That is why intensive care cardiac units have been opened in the hospital. Otherwise, there are only ICU. Patients used to come, make your indoor sleep, make you this, make you this. So much time is wasted. Until the person comes to ICU, patient is already gone. So management of time is very, very important. Okay? That is why even big countries, they have got the 747 jumbo jet, which has got everything in for the management. So they are already arranged. Okay? Suppose you are in a, you have told the management team which are possible in a tertiary hospital. Okay? Suppose you are in a PHC and a case of MI comes, how do you manage that case of MI in primary health center till you refer to the, because you will refer immediately to a tertiary hospital. But for that time do you arrange? How do you manage that?
It was the symptomatic management, like if there is oxygen saturation is decreasing, we can give the oxygen therapy. Next, the 300 mg of the aspirin is given for the patient. And if the patient is not conscious, then we can give the clopidogrel. And next, if the atorvastatin, we can.
Look here. What are the signs and symptoms of MI when the patient comes to you? It is one of the severest pain, MI pain is one of the severest pain mankind has ever experienced. Okay? So first line of treatment, okay, after you have to give. But give a shot of morphine. You have already told 10 milligram morphine intravenous, immediately you have to give. Because you want to relieve the pain immediately. Then, because it will relieve astonishingly, it is very effective. And secondly, oxygen under pressure you have to give, and then maintain the rate. The first thing is you have to give a morphine to your patient, and then because you are in PC, you cannot do much further, and arrange immediately a minute and tell this others.
Thank you, sir. Thank you, group. Now we can proceed to the